So we're going to be talking today about using data, and in particular big data, to help empower the exchange of information between patient and provider, and I hope that we'll get into some topics about how that that can be a 360-degree exchange, and some topics on patient intimacy and things of that nature. But I'm sure that the panelists will address any questions that you have. So what I'd like to do is I'd like to have the panelists introduce themselves rather, and then initially give us a few comments about some of the challenges they see in this particular area, and maybe even some of the successes that they've experienced, and talk a little bit about why they felt like they were successful in that endeavor. And so maybe we can start with Mary.
Hi, everybody. I'm Mary Whitley. I'm a retired federal executive. I'm also a past military service member and a veteran. So I'm part of that data that we all talk about with VA and military health services. Very interested in electronic health records. My current job is with ICF International. ICF International has a large public health informatics organization that I run. What I think is, what I want to talk about on this panel is my experiences with CDC, using them as an example about how they use public health data, and trying to get to patient-centered care. The top successes that we were asked to talk about first were, I would say that CDC has a mission to gather health data on the incidence of disease from across the nation. They do that very effectively. They've done that in the cancer area since the mid-90s in an electronic fashion. So it's not like we don't have a lot of data that they've collected. They're doing their mission great. They also collect data from laboratories. They collect data from mortality records. They collect data on risk behaviors that might cause diseases, and lots of other things. So CDC is a real data place, and it's a great place to work with them. The resulting research publications are used worldwide. That's a super success because our nation leads the world in this kind of research. The top challenges, though, that they've faced are basically in the area of variety. It's not really volume so much. It's more about variety, where all the data comes from. It comes from in structured forms, unstructured, text, multimedia, and they struggle a bit trying to figure out how to get the data that they need to help inform these topics in a way that is quick and effective. The processes really need to be streamlined. We talked about that a lot in the last panel. How do you collect data? That can be streamlined using today's technologies. Multiple sources there are multiple sources for the data, such as hospitals, individual providers, laboratories, the states, public health services. There's a lot of data ownership questions out there. Who owns patient-centered data? A lot of doctors, because it's in their practice, they think they own that data. They don't really look at it so much as it's the person's data, or it's data that could be used to prevent disease elsewhere if we could get our hands on it. They also, I would also recommend that a problem in challenges there is velocity. It does take a while for the data to bubble up to the national level where it can be analyzed. And we could speed that up using technology as well. And then there's a question of veracity, because all of the people who are collecting data in those doctors' offices and hospitals and various other places, are they really trained? Do they really know how to capture the data in an electronic health record? So that's my introduction.
And John, you don't know anything about CDC, right?
No, that's right, John.
Excuse me.
John and I worked at the CDC together for some time, and that's what that is a reference to. My name is John Lunsk. I am the CMIO for CGI, and I am also the vice president for our public health work. We partner with ICF at the CDC and do work there. I'm also, in the context of this discussion, I'm an adjunct faculty member at the Johns Hopkins School of Public Health in an interesting center, which is the Center for Population Health IT. And population health IT, very germane to this conversation, is this new developing area around how in and around clinical care do we use population data to better affect patient and provider outcomes. And so it's still very developing, very nascent, but that's another role I play. And then on the more traditional public health realm, I'm the chair of the public health area at the American Medical Informatics Association as well, so working with informatics and public health as well. I did work at the CDC. I am a physician, although what I've always done is health IT, and I worked in a couple of academic medical centers, worked at the CDC for 10 years on a variety of different projects and through a variety of different emergencies, and then spent time in the Office of the National Coordinator for Health IT in the last administration. This is a really exciting area for discussion, and it's exciting both because of the opportunity and because of the challenges that have to be overcome to get there. And I think from the standpoint of some of those challenges, we're bumping up right against a lot of cultural challenges. If you think about sort of the traditional epidemiologist culture, for example, versus the culture of this burgeoning data scientist position. Are they the same? Are they different? Traditionally, epidemiologists have sort of wanted to get the exact data that they wanted versus the data scientists, which is more aligned with big data and getting the data you can get to affect outcomes. Big issue. Privacy and privacy policy is a big issue. The ways in which the HIPAA and other policies are arrayed affect what we can do with big data toward these outcomes. So if you think about the fact that we have this general policy of trying to keep clinical data, patient-identified clinical data, as close to the provider of care as possible. It's sort of unstated, but it is the reality of the way we do most of the health information exchange that does occur. It sort of assumes that. Then there are other issues, like with HIPAA, there's the issue of the fact that indeed, if you are using data to add to the generalizable knowledge, this is the term of art relative to research, that if you're actually using health data to contribute to generalizable knowledge, that means that it is controlled much more tightly than it is under treatment, payment, and operations in HIPAA. And so this strange sort of irony in the fact that if you're trying to contribute to generalizable knowledge, it's even harder to use data. You have to basically get the patient's consent for what you intend to use it for. And think about that in the big data context of the fact that you're trying to collect data, amass data in great quantities, and if you have to consent the patient for the use you're going to make of those data before you collect them, that's a challenge in terms of taking advantage of some of these opportunities. And so there are a series of different issues. I think there have been successes. There have been places where some of that has broken through. If you think about when I was at the CDC, we were just grappling with this new area of biosurveillance. So biosurveillance is the concept of taking the data you can get, whether from clinical care or from other domains, whether it be from social media or other methods, and mining, if you will, those data, versus the traditional case reporting that public health had been pursuing, where basically it was said, you want this data element and this data element and this data element, and they have to be structured in exactly this way. Now, I'm not saying that's bad. I'm not saying that's wrong. I'm not saying there aren't uses for that. But we did make progress in thinking about biosurveillance, and now syndromic surveillance, which is a biosurveillance activity, is part of what every provider will be expected to do. So there are opportunities. It is starting to happen. There have been successes breaking through, and I'll pass the mic to others, as I'm sure we'll have opportunities to talk more about others as well.
Yeah, David?
Hey, good morning, everyone. I'm David Pashane, and I just finished 10 years at the VA, so I'm now on my own, so I've joined the crowd. The interesting thing about this topic for me is when we talk about analytics, health analytics, which is where I started my career 20 years ago, I basically failed in that field. I was publishing papers, doing the thing that academics are supposed to do, figuring out answers to obscure questions about what causes what disease. And I found myself more and more studying bureaucracy rather than what was cool at NIH for the day. And when I finally wrapped up my biggest study 10 years ago, it was on the bureaucracy in the healthcare field, in industry, in agencies, how it affects people. And it was considered a complete failure, even though it demonstrated the one thing I wanted it to do, which is what are the unwanted consequences when we start messing with people's health? Systematically, institutionally, what do we do to people? How do we impact them negatively? And my colleagues decided that was not Johns Hopkins worthy. It wasn't University of Washington worthy. I need to get another job. So I thought, well, I'll do something safe. I'll go work at the VA. They're a big healthcare bureaucracy. It should be fun. And I sit next to a guy named John, what's his name? No, it's not John. Actually, I shouldn't even give you his name. He took his laptop home and lost it. And next thing I know, 25 million names of veterans are lost. And I'm a veteran. My name, I got the letter that said, your data's lost. That wasn't what I wanted to do. So in the last 10 years, I've buckled down and concentrated on what are the cleanest, simplest, yet robust methods for changing bureaucracy in the context of understanding how we affect health, how we affect economic outcomes, how do we do these social policy projects and not hurt people in the process. So that's been my story. I have no idea what we're going to talk about today, but I hope I'm prepared. So go ahead, Eric.
Thank you. Eric?
Good morning. My name is Eric Candle. I'm a retired Marine, and I'm currently the staff director for the Oversight and Investigation Subcommittee of the House Veteran Affairs Committee. And to dovetail off of what David said, I'm the guy who gets very nervous when I find out there's a laptop missing with 25 million veterans' names on it. So that would be one of my requirements, is to go look into that issue to see what's been compromised. One of the things that I think everybody's been talking about is the successes and the challenges. And my perspective might be a little bit different than theirs because of the lens that I look at these issues through. And I would like to just mention 5 or 6 quick things that I see as challenges. And specifically, as I sit and evaluate and be very critical of the VA DoD IEHR. So one of the first things is supply chain risk. For those who are dealing in development or dealing in software applications or what it can do, how it can do it, specifically if you're going to be bringing in an open source code, supply chain risk has to be considered right up front. That's a huge challenge in the current development as well. You have to utilize a reference implementation model that allows proposed solutions to be tested. In other words, it's the difference between somebody telling me what a software can do and showing me what software can do. So a reference implementation model is extremely important. And these are all criticisms I have of a number of issues, but specifically as I look at the VA DoD IEHR, these are things that are in my view every day, my concern every day. Ensuring semantic interoperability, and that's basically to make sure that apples over here is apples over there. So I see that as very critical and quite a challenge. And then, of course, being aware of cost of ownership up front. It takes a level of transparency and integrity to understand what is the total cost of ownership. And sometimes I think folks can be self-deceived that cost of ownership may not be as much as in the long run it could be. I would also mention leveraging existing solutions. From a government standpoint, I don't think that the taxpayers should have to be responsible for continual innovation when something already exists that's out there. So I'm very critical of the fact, and the challenge is to leverage existing solutions. And then I would end on the good governance piece. I think good governance of any project is critical to the successful deployment and implementation of that product or project.
Okay, so we've got a number of different filters, a number of different perspectives here. So the question I'm going to ask here initially is, what do you think that those different perspectives can tell this audience? And let's just pause here for a second, if I can ask for the panel's indulgence. And is there anything that you all believe is of great importance in this topic area that you didn't hear them address or begin to address? Is there anything that is of driving need? Yes.
So, one of the things you talk about, the IEHR, I'm Joe Grace with Grace & Associates.
Hi, Joe.
One of the driving things, you can see, one of the things that's driving the IEHR is that we're going to buy a shiny object.
Right.
And if we buy a shiny object, we will fix healthcare.
Right.
And my curiosity for all of you up there is that it's kind of like saying that if I have this, I'm going to run my business better. If I don't change my processes, I don't go back and change what I do with the data. I don't change the way providers provide care. I don't change the way patients understand their care. I don't change the payment models ad nauseum. We didn't address that component, which is software fixes nothing unless you use it right. Computers are useless without software, and if you don't know what you're doing with either of them, it's just a really great guesswork. So how do you approach changing the methodology of this to actually change something?
I'll take that. If that's okay,
Sure.
John? Yeah,
Go right ahead.
So I think at the VA, what's been helpful, and I'm kind of tooting my own horn here, but looking at things through a performance engineering perspective. And that has to do with how do you get the most out of the people you have and the information you have. It has nothing to do with the IT in the front end. Now, you may have a shiny object, squirrel. And we all get excited, because it might make us look good in our jobs. But the performance engineering takes it back to the executive team and says, look, there are structural problems here, and there are human problems, human development problems. And guess what? These employees are here to do the work. And if we're not optimizing their value and the information value, then the shiny object isn't really serving the purpose. And there's enough COTS out there, there's enough off-the-shelf things that we can go test against that environment that had nothing to do with a big project, big procurement. It had to do with performance engineering. How do you get the most performance leadership out of the people you have? And that's where our investment is as taxpayers. Now, in this conference, we're largely talking about IT, and so we want a shiny object sold to the government, and there's no problem with that. But if the performance engineering isn't one of the requirements for the feasibility of that tool, then I think it's a waste of money.
So thinking about it from a health perspective, a lot of the infrastructure that's been in place was oriented to the model of payment. And the model of payment induced or at least supported the payment for procedures if it didn't induce them. And it was not necessarily aligned with thinking about populations in general. And so whatever one thinks about Obamacare, there is pretty much a consensus among health people that health reform is a critical enabler of changes in accomplishment in health. And those changes in health reform probably are the things that need to drive how those shiny objects are used. And so if you think about high tech and the investment in EHRs, it was sold as a method for supporting health reform. Now, in fact, a lot of the technology is still oriented to the previous model of care. But nevertheless, at the same time, there is movement in bundled payment methods and quality measurement in other aspects of health, alternative ways of managing health and reimbursement that will hopefully line up with the shiny object, and that's the goal. So it's not, I think the strategy is not to just look at the shiny object, but it is to try to make sure that the hard work of the policies and the activities that are fundamental to care and to population health occur so that the shiny object can actually shine in that context.
Which leads to a question for John. I'll ask a question if I can, John. Before the healthcare bill was passed, there was quite a number of studies on this very question. How will this impact the operations within agencies that touch healthcare? And there were analysis that went to oversight committees saying, hey, you know, there's some weaknesses here, even from the Federal Enterprise Architecture Office. I forget who that was. But, you know, outlined, I think it was 36 systemic weaknesses in health information that was being sort of skipped over to get to the bill before you fix the operational problems. I don't know. Is that something that is in the plan of work for you?
Yeah, Eric, you're nodding your head.
Yeah, I mean, you know, as I've mentioned to a number of folks, I'm very critical, very self-critical, but I'm very critical of industry, government, you name it. Unfortunately, that's the location that I work from, and I have to be very critical of a lot of things and ask a lot of questions. There are deficiencies. And back to your original question, or your original point, I would say, a lot of people focus on the shiny object. The shiny object being what it is, it attracts attention. So everybody wants to have a piece of that. Everybody wants to stake a claim in that shiny object because it's cool. And in the IT environment, everybody wants to build the big sexy stuff. Nobody is necessarily remembered for all the down in the trenches, IT security, you know, the day-to-day work. That is not sexy. That's muddy, that's dirty, bloody, if you will. And so the shiny object gets all the attention, and we tend to take our focus away from those very critical day-to-day things that either make or break the shiny object. And so the
Excuse me, could you explain what you mean by shiny object?
shiny object is
I know, but I would.
any software or any application.
In this case, we're talking about Epic, Cerner, McKesson, Meditech, an IHR system, and the DoD is looking to go out and buy a core, and the VA is using Vista, but again, the focus became on the product as opposed to the process. And my question was, from the
Right.
House perspective, you know, you've been so great in all this stuff. What's the view at the congressional level of that? How does it affect all the things that you're talking about?
My big criticism is that, this goes back to the governance piece I was talking about in the opening. It requires good leadership, a foundation in good leadership to identify the difference between what we're calling the shiny object and the day-to-day operations. And if you're not leading properly, if you're not addressing those leadership issues, whether those are 38 points in one particular option or one particular program or application or shiny object, if you will, and the next, it's the day-to-day operations. That's what really makes or breaks that. That's what solves those other deficiencies that are identified elsewhere. That's just my perspective.
Yeah, so if we could, let's try and get down to some brass tacks here on what needs to change to make the process more in line with the usability of the shiny object. So a lot of people were mentioning policy changes and the operational models that are currently in place. You know, what needs to change there?
Well, I'll use, go ahead.
Well, I was just going to sort of try to build from the last conversation into that, in that to some extent, we should recognize where we are with health IT, and that is right at the cusp of change. In fact, you know, EHR adoption has jumped, but it's been low for decades, and the industry has largely been refractory to using information technology in this way. So we're at the cusp of change. We have to, I think, to get to optimal utilization, there has to be a more detailed discussion. And I don't want to be a contrarian, but just reacting to what was an excellent panel earlier, thinking about big data, for example. You know, big data is great for some things, I would say analytics, and it's less good for other things, I would say like continuity of care. And so here are two major areas where here's the shiny object, big data, and I don't want to poo-poo it. I think it has wonderful promise in population utilization, in quality management, in a whole slew of other areas. But it's probably not the right tool to advance continuity of care, so that when one of your providers needs to share data with another of your providers because you're going there for a consult, big data is not the shiny object for that. But we haven't gotten to that level of discussion still. And we're still so early in it that we're still talking about things at a much higher level. And so to some extent, you know, and I'm not a patient person, but to some extent we realize that health, we need to be a little patient getting to the details of this discussion and working through some of these issues. The hard thing is to tackle some of the things that take so long to get to, and I would put policy issues in that category, and we can talk more about those.
I'd like to share an example where I think it's, we'll come right back to you, where it's been done very well. Namely, my colleague, Jack Bates. And I think he was mentioned in the previous panel. But Jack followed the right procedure, basically. He just said, look, you know, it's not about my ego. It's not about creating a big project. I have a very clear goal, and my team is going to be disciplined to create the outcome of that goal. So VA needed, we're a broad community of people, right? Researchers, practitioners, and all that. We needed a robust, detailed, and highly convenient analytic infrastructure, right? And Jack did. He pulled it off. We now have this beautiful community of analysts across the VA, regardless of who you are. Quick access, depth of access, everything from simple reporting to complex forecasting. Very few people achieve things like this, and Jack has done it very well. And I give Jack the credit. I wear my VA hat, and I give VA some credit, but Jack did it in a disciplined way, which helped him overcome the bureaucracy, the cast of characters, and get it done. And so I'm very proud of that. I think that's an example of governance and looking at the big picture, knowing your customer, and not focus on the tool, but focus on the achievement and the performance and the goals, and work towards that. And he's made a lot of adjustments, a lot of tool adjustments, because he's never made it the tool.
I'd
Sorry,
like
to
to add, if I could add something real quick. First of all, Jack is the guy who's doing all the
Jack
analytics.
Bates, call him
Jack.
up. He works out of Austin, Texas. Yeah, great guy.
Real quick on the policy piece, you know, we were looking at, for 15 years, and I'm thinking about GAO reports, for 15 years on the IEHR, the VA and DOD options, where it was two separate options, became one option. Earlier this year, it went back to being two separate options. And to the policy piece specifically, we saw that as very problematic. And I think that you were talking about this earlier, that we continue to do things and we continue to do the same things and we hope for different results. And I look back at the history of the VA DoD IEHR, and I think we have not been able to do this for 15 years, and yet we continue to pursue the same things. And I think it's extremely problematic. And so from the policy piece, this is one of the reasons why we got together from the House Veteran Affairs Committee, the Armed Services Committee, and Appropriations. We sat around a table over a series of days, and we talked about how can we fix this issue, and the end result, and part of the information that informed that conversation at the House was from a IT roundtable that we had in May in the House Veteran Affairs Committee. And so the outcome of all these conversations became H.R. 1960, Amendment 164, where we were specifically saying we can no longer do the same things and expect a different result. So we are now saying you have to do these things in order to get to the result that you say you want. So now whether or not Amendment 164 passes, and that's the NDAA, H.R. 1960 is the NDAA, I would certainly hope that this thing passes, because if it doesn't, the option is to continue doing what we've been doing for 15 years and hoping to get something different, and I just don't believe it's going to happen. There are good things coming out of VA and DoD, but I don't think that those good things are going to get us to the end result that's been desired and professed for 15 years. So I didn't mean to cut you off.
No, it's okay. Thank you. So I want to pull the thread a little bit further on this issue of what needs to change, and with one specific area in figuring out what to do about privacy. Right? So there's two extremes. There's either I am implicitly okay with it. Just let my information in the ether because I want everybody to have it in case it's needed. Right? So that's one extreme. And so, everybody get over it. Just I want it out there, let it go. And then there's the other extreme, which then implies there's a consent engine that everything is aware of, everyone and everything, and it's in everything, right? So that's the other extreme. And so when you look at policy today, where we are with things like HIPAA and the privacy rule, they're woefully inadequate, right? For really enabling this empowered patient and provider and device and market, all the stuff we saw last night, our policy's not even close. So my question then is, where do you see it going? Right? Where do you think we are? Are we going to hit one of those extremes? Are we going to be somewhere in the middle? And what needs to evolve to get there?
Can I take a quick stab at that?
Sure.
I'm not sure what the other folks think about the laws and whether they're adequate. But again, from where I sit, I look at the number of laws that already exist to protect data, from the Privacy Act, high-tech, e-government. I can think of probably 7 laws right now. Some of them are probably duplicative in protection of personally identifiable information. I don't know if it's the law that's deficient or if it's the implementation of the law. And I would argue that more likely than not, it is one, human error in how people might not think about the protection of that information, as David talked about earlier, sitting next to the guy who lost the laptop with all the names on it. Well, the law says that information should have been encrypted, and I don't believe that information was encrypted. So the law is already covering that. It's human error that we didn't encrypt it. It's human error that we lost the laptop, probably human error that we took the laptop home or wherever we lost it. So I think the question is, are we properly implementing the laws that currently exist in both a virtual form and reality?
There have been a lot of laws written since 2006.
Yeah.
So one thing I'd like to add to the question from a challenge standpoint is the patient identifier, the lack thereof. And in fact, as indeed things move forward, when it is increasingly demonstrable that a patient's care suffers if their data are not matched to them properly. That's the good side. That's the reason you want a patient identifier, is or something to serve in that purpose. And, but having been in government, I almost had a little bit of a nervous breakdown right there when I said might want a patient identifier, right? Because we're also, it's entrenched in us that there is no patient identifier for health, and that there's no funding for it, that this has been the traditional take on that. Well, we need a better strategy. We need to, and so let me just add that as a problem, that the way in which you can match a patient's data to them, not as big a problem perhaps at times in the VA and the DoD because they're more closed systems, but a generalized problem and one that impacts them when care is received outside of those walls, and in the private sector, it's a huge problem as well.
So the issue of leveraging the data, if you actually want to leverage the data to change, going back to Eric, your point of doing the same thing and expecting a different result, our payment model presently doesn't allow us to use the data to do prophylactic medicine such that you actually keep people healthier, to take women over a certain age that need mammograms and make sure they're identified. We can tell you to change oil in your car, but we can't tell you to go get a mammogram. To take men to get prostate exams, to take different people, patient-centered medical home, but the payment model, whether it's VA or DoD or in the private sector, doesn't support good health at all. It supports reactive health, not proactive health. So using this, how do you see those two coming together? Because without it, it doesn't have a whole lot of purpose if you can't use it the right way and people only get paid for doing stuff actively. So I throw that out to the CMIOs.
But prevention services are covered under the Affordable Care Act. And so there is change. I'm not saying it's rationalized with what actually occurs, and that's part of my that we're on the cusp of this, but there is the opportunity to get reimbursed for preventative services in the Affordable Care Act as that progresses. That is a change to the environment that hasn't necessarily taken hold. And there's complexity too. I mean, I'm not pretending that covers all the needs. The concept of doing bundled payments, the concepts of other payment methodologies is by no means completely spelled out. Accountable care organizations are nascent. The pioneers have just reporting back from their first work, and there's a whole lot out in front of the country in that regard. But those are some of the elements that I think need to get addressed.
And I also think it's changing over time because 10 years ago, the state of Kentucky could only get disease surveillance records out of their hospital systems by watching the electronic financial transactions go by. So every time a financial transaction went by for a person being treated in the oncology department, that was a tick. We've got a cancer patient. Today, we're actually doing much more than that. Today, we're actually getting information out of the electronic health records that is the size of the tumor. When were they diagnosed? How are they being treated? And we're going to start adding up that data to do what they call patient-centered outcome research. And I think as a patient who's suffering from cancer, you not only want to know about your own disease, as John was saying, the longitudinal disease you have personally, but you also want to know about all the other 25 million cancer patients who have similar disease to yours, and how are they being treated, and what is the comparative effectiveness of that treatment on their disease as compared to your disease. So I think there's an opportunity for big data right there that may be solved when electronic health records capture more than financial data and are able to share that financial data.
So another public health example that I think is emblematic is that, whether you all know it or not, reporting of infectious diseases has been historically very poor. So in the teens of the actual, for example, tuberculosis cases that are incurred or found in clinical care, very low percentage have historically been reported to public health. The process was, in the paper world, that the provider needed to know who to contact at their health department. They needed to fill out a paper form. They needed to get that form to the health department, and it just didn't, for a variety of different reasons, didn't meet with a lot of success, has not met with a lot of success. One thing that has changed that dramatically is electronic laboratory reporting, wherein the testing lab that actually tests for tuberculosis reports that case, that potential case, to the health department electronically. And so the provider is not in that immediate loop. Well, it's led to a significant uptick in the number of case reports, but think about that. That's disintermediating the provider in a way that is culturally very challenging. And it had all sorts of issues with local and state health departments because they went around, so, in some respects, particularly the locals were upset if it was going directly to the state. And whereas historically the data flowed clinical care, local health department, state health department, suddenly it's going lab to state health department. And that that was problematic. So there's a lot of cultural change, a lot of challenges with that, but when it is a solution that has made a huge impact.
So that seems to bring me to a migration of population health practice into the practitioner's office as we have accountable care organizations stood up, and we start to have different things like bundled payments you mentioned, John, capitated payments. So now you've got the practitioner who necessarily needs the information that you just described to be accountable truly for his population or her population of patients. And so how do we make that happen? John,
I can frame a little bit of the problem in that regard. Think about in terms of meaningful use, in the initial efforts around EHRs were to just allow an EHR to list the patients by a particular disease. This is basic, This is just the start of a population-like activity. So the initial population activities were just, instead of thinking about the EHR as a way of just supporting the recording of care, well, turn it around. What patients do I have that have a particular disease? That was a function that most EHRs could not immediately support. And now they're going to, and that is progress in this direction. But it's also an interesting time relative, if you think about some in public health, where government has basically been advancing public health activities like surveillance and population-related prevention and things like that. Now there's an effort to ascribe those, government historically didn't have the money to do it well. There are kinds of privacy issues, all kinds of privacy issues around government having patient data. That's always been an obstacle and an issue. And now with the Affordable Care Act, you're thinking about healthcare having some of those responsibilities. And it's said in a very negative way, some in public health are thinking, oh, they're reinventing the public health wheel. And they're starting from a very elementary state. And so there's a lot of learning and a lot of collaboration that needs to occur between public health and clinical care, because a lot of this groundwork has been done, and the ways in which electronic health records can be used to population health purpose, we're just at the start of that. And to be honest, it's more than electronic health records. The oxygen has been sucked out of the room by $15 to $25 billion worth of investment in electronic health records. But if you think about the applications that need to do population health, those aren't necessarily what are traditionally EHRs. They're data warehouses, there are case management tools, there are all sorts of other things that need to be in place in healthcare if it's going to handle population activities, and it's not just about the system that the physician uses, that the other ancillary healthcare providers use to provide care directly.
But the opportunity really is to, once the data exists in the electronic health record, and you have access to that data for population health purposes, you have the opportunity then to aggregate very, very large data sets, which normally in cancer surveillance, that means 15 million annual records of people who have been diagnosed with cancer, or it means 25 million people who died of it annually. But there's a whole lot of other diseases out there, and you can think of how the big data aspect of this would really come into play, because you're going to be managing all these diseases and all these behaviors that you'd like to track in very large data sets at CDC someday. So I think the cow path needs to be changed, because right now it's a form, as you said, that is actually an electronic form. So it doesn't actually have to go on paper. But to get people to sit down and in a provider's office, for instance, and give the data that's needed in order to do cancer research later, cancer statistics, is very problematic. It's a lot easier from a big hospital system, but there's a lot of people who will never, don't go to a hospital for their disease. And so how do we get to those people and get them to be able to offer the data that we're talking about?
So integration of social media and other data sources, genomic data for personalized, a lot to do in that regard to get to that point. And just a lesson from sort of the biosurveillance world, when after the anthrax attacks and biosurveillance became something that seemed like it made sense from a preparedness standpoint, there was a lot of discussion about what biosurveillance was. So if biosurveillance is taking clinical data and using it for a population or public health purpose, there was a lot of talk about what it was trying to identify the index case, trying to use an algorithm that allowed you to identify the event occurring before a clinician actually saw it. That was the conceptualization, and there was work in the academic community around that. Well, it turns out that clinicians are pretty good detectors. And it turns out that while there have been some successes in that space, that's not where these big data have really shown. Where they have done really well is in what one would call situational awareness, where it's not necessarily identifying the first case, but it's when you have that first case identified and you know there is an issue, managing it. There's such a thirst for information. Every emergency I was involved in, you wanted more, more, more. In anthrax, if you'd known that there were people coming into emergency rooms with cutaneous skin lesions, you would never have, you would never have, or be very unlikely to identify the anthrax attacks by virtue of the fact that people were coming into the emergency room with skin lesions. But having known that there was an anthrax attack, you could go to emergency room data and say, boy, we should be looking for skin lesions because that is one of the things that we could find. So you may not have crossed a threshold in an algorithm to say there's an attack going on at that point, but once you fact that you know that something's going on, you want to be able to look at those data. They don't have to be as clean, they don't have to be as perfect, but it gives you a much better sense for the fact that indeed something is going on, how big it is, where it is, how it's spreading, all those kind of situational awareness things. So the outcome was different than what one went into it thinking about, and that some of that comes with time. It wasn't, the immediate outcome was not necessarily identifying the first case, which is a very challenging endeavor, but it was, in fact, huge benefits in situational awareness of knowing and managing after the event is recognized.
If I can add to what John and Mary have talked about, just a policy perspective, going back to your earlier question on policy. I don't know how many people are aware of it, but in federal health care, you voluntarily submit information. Let's say if there's an infectious disease, you voluntarily submit that information in the state, it's part of state law for a state hospital and whatnot. That's a requirement, but at the federal level, it's voluntary. And so this gets into a critical aspect of being able to bridge the difference between the healthcare, the analytics and the tracking, and providing that care with making a mandatory reporting requirement at the federal level. And from a policy perspective, we saw this in an investigation that we've been doing for roughly a year in a particular region of the country where certain infectious diseases were not required to be reported. It was voluntary. They did not seem to be reporting them for various reasons. So we crafted a bill, because it's not passed into law yet, and we said, you don't get to volunteer this information anymore. You must report this because hospitals at the state level are required to report it, so federal hospitals should be required to report it. So that's the policy piece of what they were just talking about, in my mind. All very valid perspectives, but we have to make sure that we're enforcing the policy aspect of it so that it's a fair playing field for one, but two, for the national health scene. I think we have to keep that in mind.
So, please, go ahead.
Hi, I'm wondering a little bit of Accenture. Thank you all for this panel. Very interesting so far. I've been thinking about this from my business perspective, but taking a step back as your JQ patient, I'm hearing about my doctor and the hospital and the state and the local and CDC and everybody else wanting my data and wanting to do things with my data, and I'm not hearing a lot about me. And just I keep staring at the screen and thinking about empowering the patients. So we're going to have to get to a point with this discussion where we get the public behind it, whether it's, you were saying, John, with consent or however it ends up manifesting. But I would love to hear your thoughts on what are we going to tell the community, all of us, to really get us behind this. What benefit will we get as opposed to talking about, oh, well, this agency can track, great, and I can follow those links, but maybe not everybody can. So what's the message going to be to the public about what benefits will come from this?
Great
I think
question.
the message really needs to be, the self-serving message about the more you know, in that commercial. Because I think the more we know about disease in all of its various forms across the nation, for all the people who have it, the next person who gets it is going to benefit from the data that we have just analyzed, and we've figured out what are the most effective treatments, and we provide the best possible health care solution to the treatment problem.
Population health is patient health. And I think the Blue Button Initiative is a wonderful initiative. I think it's a necessary initiative. I think it's appropriate. But you know what? patients have not yet engaged the management of their own health data. You can look at the PHR endeavor as it has been articulated, at least in some circumstances, in terms of Google's and Microsoft's effort in this regard. And patients, and there are all sorts of obstacles there. I'm not criticizing those efforts, but patients want their data to be accessible by their provider to treat them properly. That is a paramount need. And should they be able to download that data? Absolutely. And is there a possible future where they will be the intermediary, as health information exchange intermediary? It's possible. It's just not happening yet. And there are all sorts of cultural issues with providers not wanting to get data from the patient. There are all sorts of data overload issues where it's not enough that the provider gets a patient coming in that has downloaded all this information from the internet that they have to help them sort through. Then they're going to have their oodles and oodles of their health record in unstructured form from 5 different EHRs. That's not a pretty picture. And so, from a provider standpoint, there are still issues there. So, I do think that Mary's onto something in terms of saying, that enabling the patient is not just a question of direct services. I think those direct services to the patient are absolutely appropriate and investigatory. They're necessary from a policy perspective, but there also is the need of having population health advanced, because that actually improves patient care and prevention.
I'd like to take a slightly different angle on that. I might have said some of the same things, but I think there's things that we're overlooking that go to the heart of your concern, and that has to do with patient agency. Fundamentally, healthcare is a function of the way we engage our health, self-direction, self-control, and every time through our lives that we interact with the health system, we receive cues that tell us how much control we have or don't have. And when we experience a disease or injury, there's that sense of deprivation, diminished control, creates fear, anxiety, and we look for somebody else to step in and help us out. But we're still shaping that patient agency. And too often, in large systems, big ideas, we overlook the way that unintentionally we diminish that agency. We take away that self-respect and dignity. Now, I'm not saying that these aren't great ideas in order to explain cancer treatment over the course. But we have a lot of untapped data, like at the VA. We've only done a few studies where we look at clinical data as a population model. And it doesn't require everything. It's sampling, it's statistical modeling. You can do it with a small sample. But the point is, we haven't used the data we have very well, and yet we're running down this course, ignoring the fundamentals of health, which have to do with your agency as a person. Personhood still counts in health outcomes.
And if I can add to that, I would love to be able to go to my doctor with all of my medical information on my iPhone or my BlackBerry or my iPad or whatever. That would be great. The problem with that is it's not actionable for the doctor because it's on my phone. It has to be actionable, one, but two, we were talking about Blue Button. There's lots of great apps out there. You can track all kinds of things. And this, I think, is what John was talking about. This is all unstructured data. So, one, it's unstructured, and no one's going to be able to make heads or tails of it. And two, it's not actionable. So, we've got to be able to address those two issues. And honestly, in our discussions with the IT industry and with the folks on the Hill, that Amendment 164, specifically addresses that because it needs to be part of the conversation. And some folks are having that conversation, that's great. But we need to be able to not only have the conversation, but translate that impact to you. That's the empowering the patient. So you're empowered and you own your information on your phone, but nobody can do anything with it. So it's of no value to you. Yeah, you can see your information, but a doctor can't take action on it until there's a chain of custody to make sure it's not been manipulated, and it has to be structured so that they can see it. You know, it's great that you can take photos. Oh, this just happened to me. I twisted my ankle. Here's what it looks like, but you can't do anything with it because it's unstructured, and it's never going to make it into your record in time for it to be acted upon timely. By the time you get to the doctor's office, they'll go, oh yeah, you've done something to your ankle. Oh yeah, I've got a great picture. So it's just things to think about. Yes, sir.
Explain for the neophytes in the audience, what are the requirements for the information to in fact be actionable?
Well, I think it's a great question. In order for information to be actionable, well, I would say the easiest way to translate that is it has to be usable. It has to fit. This gets into the structured and unstructured issue. It has to be able to move into an application that can be interpreted, that speaks to the physician. You know, if you look at unstructured data, this goes back to the example of taking a photograph. That's great, but even if you could upload this to your EHR, your electronic health record, is anyone going to see it before a doctor actually looks at the injury itself? Is that image going to be structured and moved to your provider before you make it to that provider? Probably not now. Now in the future, I would like to think that it can be. I'm sure it will be.
I think it is now.
In some ways.
In some ways, it
Yeah.
is.
Some ways, yeah.
I mean, we're threading 4 needles here with one piece of thread. You know, you have the question of reimbursement, population data for modeling outcomes, and the laws that allow you to exchange private information. And now that I've left the VA, I can actually talk about products. Is that right, Roger? Yeah, okay, so an example of something that we tested at the VA I really like is Claros MedTech, right? It's a monitoring tool for the patient, but it's sending, at their permission, to send these signals through their Bluetooth to an algorithm that's translating that into signals back to their doctor, who's going to get reimbursement for consultation, but the algorithm is also managing the case, the whole set of cases, in order to not overwhelm the doctor, to prioritize, and that's also generating a data set for great analysis. And I mean, that's now. We've been testing at the VA, and it's beautiful.
So that's one thing that I wanted us to touch on a little bit is the patient engagement and the patient-provider interaction, particularly within the context of accountable care. So who are the accountable parties? I mean, we're trying to make it the provider, but doesn't the patient have a role here as well?
Absolutely.
Yeah, and in fact, that's, you know, from the standpoint of meaningful use, some of the measures that were most resisted by providers were those that were actually for the patient. You know, so how, you know, the trouble, a challenge is that, you know, $15 to $25 billion worth of incentives around EHRs going to providers does not bind the patient to doing anything. And it doesn't necessarily bind other parts of the health industry to doing things, it binds the provider to doing things. And so, for example, if you're trying to have the provider ensure that the patient downloads their history or their record from your website or does something else, if you're a provider, how can you ensure that they do that? How can you be held responsible to the point if you're a provider for their actions and behaviors?
That's right, that's right. And we have a question down front?
Yeah, I have a question. So when we talk about empowering the patient, as a patient, I've gone out and taken charge of my own personal health care because I have a series of different doctors. I have a VA doctor, I have a regular doctor, I have these other doctors, and they're not connected. There's no, you know, I have to be the one innovator that signs off on the form to get her data transmitted back and forth. Okay, fine, moving forward. Well, I'm kind of like a lot of people in the audience. I also go to buy and shop and all over the place and buy supplements. Somebody who's here to take supplements, right? Okay, so I'm taking charge of my personal health care because my doctors aren't addressing my needs. So if you talk about prophylactic health care, and that's what that is. You know, I see the things that happen to my parents, some of those lifestyle choices, some of those, you know, this genetic stuff. You know, and how do I avoid that outcome? Well, I'm going to go to Vitamin Shop or wherever and take the supplements I need to take, by gosh, and I'm not going to wait for the doctor to say, hey, you've got a tumor or whatnot to address things. And so when we talk about empowering patients and practitioners, I am number but I will take that stance. And that, I think that there's a lot of people like me out there, otherwise we wouldn't be somebody buying the shop or other supplements, right? I can't be the only one doing that. So that's kind of part of my thought when we talk about empowering patients. I think some patients are empowered, it's just we haven't been, not been specific with the medical community.
And they've been frustrated by the infrastructure exists. If you want to manage your health information, it's very hard for you to do so right now, and to carry it from provider to provider. So that's very frustrating. But there obviously are also populations that can't and won't. Sometimes, and that's not a reason not to attack the infrastructure by any means, but there are some that need help, and the whole concept of ombudsman, for example.
But if you put it up, if you put people like me in a position where we can do that, we are the same types of people who got the first piece of technology. Everybody said, hey, what is that thing? You mean you can listen to music on your phone? You know, now look at how many people listen to music on their phone, do all kinds of stuff on their phone, right?
Yeah.
So I think that if you empower people like me, you will get the result that you want throughout the community. And it will take longer for those people who are technology resistant, but guess what? Those people always take long.
And the point was made on the previous panel that it does melt away a lot of the policy and privacy obstacles if the patient has the right to move their data where they want to move it. But there are these issues around access and provenance and whether those data are usable in a care setting, and those are things we're still in front of us.
So
Please, go ahead.
Usable data, but explaining a situation where we have all these doctors, you're the one, who's the one who's communicating between the doctors? They're not communicating. You're the avenue. So if you can have accurate data on your phone, because the truth of the matter is, you fill out that form on paper every time you go to the doctor. Allergies, do you have any? Have you had any procedures? Let's face it, I don't remember. My forms, and they're probably all different. But if I actually had something that actually could remind me of all the things that have actually happened in my life, especially the ones that I don't remember because my parents took me when I was a kid, that's already leaps forward on where we are now. So it's not unusable. It's unusable in the sense that it's not machine-able, but it's not unusable in the sense that it might actually be accurate and provide your next doctor with the information they need to do for that.
What's funny about that statement is that vision you just described was created 10, 15 years ago by several companies, including one I owned. And, it kind of died out for one reason: the laws. I mean, basically, and largely pushed by public health folks, right? I mean, I'm standing in between the two people that killed my company. Part of it is because the information is not that complex, but there's people that want to use that information. And so we get down to who's going to advocate for you in terms of, are you forced to release that information, or are you going to offer it up freely? Because there's pressure to get that information for good reasons. But I think overall there's a layer here of bureaucratization that we ignore, and yet it has an effect on healthcare, and it has an effect on patients. And there's a little known study that showed that even indirectly, the more you bureaucratize, you try to over-control a system, it has consequences on patients, even if they're not directly in that food chain, because it changes the attitudes and the performance of providers, right? The provider's no longer your doctor next door who really cares about you personally, Joe, and says, hey, Joe, how's it going? It's really like, hey, you are a number. I have to get you through the system. There's throughput here. And I need to get down, and I have to get your data to the health department quickly because they're doing a study on your particular disease.
But the other part that we're not addressing is most of it you don't need to share and no one cares. Most of it you don't need to share and no one cares. If I sprain my ankle, I put ice on it, I fix it. The second I have cancer, I have something that I want a whole bunch of specialists involved, now I care.
Absolutely.
And so there's the trending, but there's certain things, you cut your finger, you fix it. That's not a national security item, and it's not something that needs to be in my record. And the fact that I use 4 Band-Aids instead of 2 doesn't need to be a matter of structured data.
Right.
And so if you talk to providers, and most humans are healthy until they're not, you don't care about your health until you don't have it. You don't care what provider you're using until your cell phone doesn't work. And you don't care about your car's maintenance until it stops running. And so part of the problem is 90% of the data that we're collecting, no one cares about.
Right.
It's the 10% that really matters, and how do you separate those two, and when is it necessary to share it, and when is it not? I think that's part of the issue, is we're overwhelmed with stuff that just doesn't matter. So how do you address the non-matter part? I'd be curious to you.
I think Mary addressed it, I mean, about why you do this. So like, I have Lyme's disease and I have degenerative arthritis, both conditions I would love to be involved in studies, and I would volunteer up that information so that I, as one case, could be part of the knowledge base, right? So write all this down, Joe, and send it to Eric. There should be a bill that says, look, you know, there's good reason I'm motivated to get my diseases studied, but I don't need you to know about every single ear infection I have. I don't.
So I heard a couple of different things here. Number one, I heard that there is an opportunity for innovation to allow for the technologies and the data to flow more freely from the patient all the way through the institution of healthcare. And I also heard that there are impediments that maybe only the government can address. And I think that you mentioned, you know, a modification, a legislative modification that's about to occur that might do some of that. But I think that that's what we've really ended up with here. Is there are great opportunities, and but we have to take the next steps. The last thing I'd like you all to address is this concept of sharing of data and approvals of that sharing. What do you think the role of generational change will have in that paradigm?
Can I complicate her previous statement a little bit?
Sure.
When you were talking about, and David mentioned the laws, you were talking about your healthcare information going from one provider to the next. I don't know that that's necessarily the law that's making that difficult. It could be to a certain degree, but I think what you often find is Dr. A believes he or she owns that information you gave them. And so when you go to Dr. B may or may not contact Dr. A for that information, and Dr. A may or may not give that information to Dr. B. And that's an issue of confusion of ownership. And it doesn't make your life any easier because you're saying, well, I went and saw Dr. A for this. Well, we'll try to get that information from Dr. A. Meanwhile, days later, you're still waiting, and that information's either not been shared or not been requested.
But it's also business proprietary data concerns. And listen, it's hard to use standards. It's not easier, it's harder to make those data so that they're comparable. You know, every hospital has historically used different codes for different things. And to all go to one for whatever purpose, that's very hard. So it takes a lot of effort. And the incentives have, frankly, not historically been there to make that effort.
Right. So we have one last question from the audience.
Real quick, when all this data is available and can be shared amongst physicians, and there's an expectation of better care, when people still die because people are going to die, there are going to be lawyers that say, well, this doctor should have looked at the data this particular way. It was all there. You didn't do the kinds of things you should have done. You didn't read this doctor's report, that doctor's report. The malpractice lawsuits, the opportunity for malpractice lawsuits and the opportunity in our litigious society for people to want compensation or want to fix a situation that's not fixable because some of these people are still going to die. I mean, that's going to drive up healthcare costs in some ways too. And you're going to get doctors, I think, that are going to be skeptical or scared to take I want your data and I'm going to give you better care because now you just increased my risk of me not doing something somebody, a lawyer, thinks that I should have done. I don't hear anybody talking about that aspect of it, but I think that's going to be a very important point at some point down the line. And what can doctors do and what are their requirements when they receive your data? Do they have to read it and use it?
To me, it's just due diligence, but you're a doctor.
But
so.
that issue is what underlies a lot of what I was alluding to before about information overload to the provider, is the concern that somewhere in the masses of information that are being now electronically provided to them, that there's something that they missed or something that they could be held to by someone else, when on a practical basis and you've got 12 minutes to see the patient in the room because you've got a queue of patients behind them, it's almost impossible to sort through all that information. And so that is one of the underlying reasons that data overload issues is so prominent.
And with the med tech I mentioned, the approach has been to write that algorithm with the experts in that field, vetting it up front to say, if these signals, then these choices. And so that logic tree has already been laid out to protect those doctors from following those signals.
Yeah.
And that's an important tool.
So I'm going to have to draw this to a close. We're beyond our allotted time, but if the panelists would go down, maybe Eric, you could start, and give the audience one takeaway that you'd like them to walk out of the room with.
We talked about a lot of things. I'd like you to take a look at H.R. 1960 Amendment 164. One of the critical pieces we were talking about and didn't elaborate on was open standards. These standards that everybody can interpret the same way instead of proprietary standards.
I would say go back to the basics of performance engineering, recognizing the context of these things are bureaucracies, and that operationally they need to become enhanced before any of the tools, shiny objects, or rules really apply.
One thing is to bear down, educate, dive another level down into the content, because a lot of the solutions are going to come from just a little more knowledge and a little more analysis. And there are a lot of great shiny objects out there, but we have to get to another level of cultural and policy change, I think, to really take advantage of them.
Yeah. Mary, you get the last word.
Oh, good. I would say that as John started out his discussion today with, we are at the cusp of major change in healthcare. And the way it's going to be delivered, the information that people are going to act upon, and the way the patient interacts with the healthcare system. And I would say the message is get on board. I mean, it is time to start driving some of those changes, both in your selection of your doctors and which healthcare network you work with. If they have electronic health records, get on board.
Okay, everybody, join me in thanking the panelists.